So basically, I mean, this lecture is on working up complex neuropsychiatric symptoms, and this is something. Why? I mean, if you look at the top slide, it says I have been told, and this is the way pediatric neurology, or even in simple words, adult neurology, like internal medicine neurology is taught. They say it's quite simple because just like mathematics, if you know the distribution of the lesions, like let's say sensory distribution, or let's say if somebody is having muscular problems or absent reflexes or something, and you just figure it out that which levels are affected, then it's easy to pinpoint which part of the nervous system is affected. They say it's as simple as that. But I think it's easier said than done. That's it's not that easy. It's not that easy, and especially in pediatrics, it's the opposite. Like it's very complex. It's not simply 2 plus 2 is equal to 4, and just by saying somebody who's got, let's say, loss of let's say knee jerk reflexes and has got glove and stocking paresthesias is equal to this. Like it's more complex than that. So this was just a sarcastic image, like somebody said, pediatric neurology is simple, and gets a slap in the face that never say that again. Okay, to those who have been through that, they know how difficult it is. And picking up this topic is because many times, I mean, especially when we are talking about neurological symptoms, I mean, let me slightly define these two different fields, because there is a bit of overlap, and we need to understand where is the boundary of neurology and where is the boundary of psychiatry. So neurological symptoms, that if somebody has got symptoms like paresthesias, or diminished sensations, or increased sensation, or motor weakness, or gait disturbances, or hemiplegia, or hemiparesis, or fits, seizures, we classify these as neurological symptoms. Some of the general symptoms have also got some of their boundaries. They go into the neurology, like for example headache. But then there are certain things which are purely psychiatric, like for example somebody who's got problems with their thought process, somebody who's got problem with their emotional lability or emotional stability, people who have got problem with their personality, people who have got problem there with their mood, people who have got problem with their social interaction with other people. So that is considered to be more of a boundary of psychiatry. So normally we have been trained the way that neurological symptoms have something to do with the nervous system. Psychiatric symptoms or psychiatric pathologies in the air, it's more something to do with your personality or upbringing, or maybe something which is beyond your control and beyond our domain. Problem arises when you have got a mixture of these two jumbled up together. If somebody has got neurological and psychiatric symptoms as well, and where the things start getting murkier, because the issue is it sort of a psychosomatic phenomena? Is it a physiological manifestation of a psychiatric illness, or is it a psychiatric manifestation of a neurological illness? Now this is the biggest, it's a catch-22 position, because I mean it looks as simple as that: either neurological manifestation of a psychiatric problem or psychiatric manifestation of neurological problem. As simple as that. But the issue is that simply dividing these two then opens up the boundaries or gates to hell, because then there are so many pathologies within each category or each domain that needs to be worked up. And the problem is again that as I say again and again and again, kids, they do not read textbook. They never read textbook, Nelson textbook, or Arniel Forfar textbook of pediatrics, for that reason any other textbook. When they come, they've got all these weird types of symptomatology. And recently research is showing that many manifestations, psychiatric manifestation, which we put down to, let's say, poor upbringing, or the way your genes are, or the way that you have learned from your environment. Well, to some extent it might be true, but there are certain illnesses which can present in a very treacherous manner, and basically they are organic pathologies which can present with profound psychiatric manifestations. And that's one of the reasons that many of the psychiatric interventions, they do not work. I mean, how many, you know better than me. At least we see 4 or 5 mental health presentations every day. Every day. Fine. Majority of them are very straightforward cases. We know they are known to the mental health services. They have been doing self-harm. They've been taking overdoses. They've got problem with their behavior, with their, let's say, emotional lability or emotional control, blah, blah, blah. Fine. But there are certain cases which have got some like coexisting neurological symptomatology. I mean, it might seem very subtle, like, somebody having tics or somebody having numbness on and off, and we put it down to psychiatric illness. Oh, because he's got this problem, he has got mental health issues, so he can have all these types of issues. He would be having loss of sleep. He can have these what you call conversion disorder, non-epileptiform seizures, blah, 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 etc. So this lecture, I'm going to take a deep dive into how do we approach complex neuropsychiatric symptoms. Okay, and I will start with giving you a few scenarios. Okay, and if you go through these 3 cases, which you might, can you see that on your screen, these complex cases? Okay, so if you look at the first one, the symptoms, somebody who has got aphasia. Aphasia means is like, at times becomes mum. Okay, it's not able to speak. Okay, while his other fine, has got tremors, has got nervousness. Okay, like anxiety, and this has been happening for the last 2 years. Has become introverted. Introverted is not talking too much. Sometimes stops eating for days. So thinking of like maybe some eating disorder as well. Has been angry, talking and laughing with himself, and sometimes couldn't walk. Like he says he can't walk. I mean, he's got no energy, or maybe, and he cannot sleep anymore. So if you look at this thing, I mean, on the face value, what do you think? Looks like a psychiatric problem or not? Look at the other one, like the somebody who's got like blood pressure. So one reading of blood pressure is quite high. Let's say this boy is 15 years old. Like, let's say the blood pressure is 142 by 80. 80 is fine. I mean, he's not got any sort of like, underlying renal pathology or something. He is known to mental health services. I mean, he's got depression. He gets hallucinations. He is also suffering from seizures, let's say, for which he is under someone and he is on some medication, let's say Keppra or like Valproate. He has also got like anxiety. He gets nervous. I mean, he also has got issues of where he can't walk for days. He becomes like bedridden, or he can't sleep, or sometimes he seems confused, like he isn't like capable of answering questions, or probably he's not answering and is a bit introverted. Again, what would you think like of this particular case? Yeah. What am I mean, there are 2 types of that. Like, let's say once is let somebody who all of a sudden develops some form of neuropsychiatric symptoms, fine, and somebody who is known to have something and they are, let's say, representers for one reason or the other reason. The bottom line here, before I go further, is like 2 types of approaches. Number one, if a new case turns up, like somebody who never had these symptoms, all of a sudden this is the first presentation. Now in first presentation, it becomes more sort of important to rule out that there is no underlying organic pathology. And for those who are representers, like, I mean, again, obviously, in that particular case, some workup must have been done, some form of, history taking or examination, or some form of a deep dive into their circumstances must have been done already. So then the question is, and let's say if they are not responding, I have seen so many times, when some of these mental health patients, presumably mental health patient, oh no, he's been on this. Somebody is on high dose of fluoxetine, it's not working. Okay, somebody is taking up the anxiety, is not being helped. Okay, he's been on this, like, and what they call atypical antipsychotics, still some of the, let's say, supposedly uh, extrapyramidal types of symptomatology, like for example tics or tremors or these jerky movements, they are not going away. Now in that particular case, I mean, as a clinician, I'm not saying as an ED doctor or as a pediatrician, just as a simple clinician, as like Sherlock Holmes sitting in, is this diagnosis which he has been labeled so far, is it correct? If things are not working, is it like sort of a easy off that, like a statistical anomaly where things are not working, or is it a misdiagnosis? The problem is somewhere else and the target is something else. So having said that, let's move on. Some complex neuropsychiatric etiology. I mean, before we go into, I will give you, and the list is quite a big one. So, where children can present with neurological symptoms and psychiatric symptoms as well. So, just imagine like any type of psychiatric symptom, whether it's the problem with the thought process, problem with their emotions, problems with their social interaction, problem with their mood, problem with their behavior, blah, blah, blah. Problem even with their academics sometimes. So, some inborn errors of metabolism, especially phenylketonuria, maple syrup urine disease, and Wilson disease. Okay, phenylketonuria, you know, it's the problem with the metabolism of amino acid phenyl alanine. Maple syrup urine disease is another, like, you know, branched chain, or what you call amino acid metabolism problem. And Wilson disease, you know, is basically problem with the copper metabolism. So these inborn errors of metabolism, especially phenylketonuria, MSUD, and Wilson disease, they can present with neuropsychiatric etiology. Now, I mean, the next, phenylketonuria and MSUD are part of the Guthrie test, the day 5 heel prick test that is done as a routine in UK, screens for phenylketonuria, it screens for maple syrup urine disease. Yes, one thing which is not screened for is Wilson disease, but obviously Wilson disease does not present in early childhood. So usually it would present by the time they are teenagers. And again, when we say, oh, Wilson disease should be easy to diagnose because they have got this Kayser-Fleischer rings. Not everybody has got Kayser-Fleischer. Majority of the Wilson disease patients, they do present with neuropsychiatric symptomatology. I think only 20 to 30% of them, they would present with Kayser-Fleischer rings, and that would also be somewhere later before, like, you know, I mean, it's not that that is the first sign to develop, you know, where we would do the eye examination and you say, oh, well, this is Kayser-Fleischer rings, so he must now be screened for Wilson disease. Though, I mean, by the time Kayser-Fleischer rings they develop, so already he's got neuropsychiatric illnesses. So some inborn errors of metabolism, especially phenylketonuria, MSUD, and Wilson disease, they can like present with neuropsychiatric problem. Immune-based encephalitis is another one thing. Encephalitis. So when we think of encephalitis, the first thing that comes into mind that encephalitis would be a very serious condition. That should be having high-grade fever, sepsis-like presentation, seizures, low GCS. Well, fine. I mean, that is the typical scenario of acute, let's say, herpes encephalitis or West Nile, what you call West Nile virus fever, or Japanese encephalitis. But the immune-based, here I'm not talking about viral encephalitis, I'm talking about immune-based encephalitis, because again, a common mistake which I think even we pediatricians, when we say encephalitis, the first thing that comes into mind is viral encephalitis. Fine, fair enough, viral encephalitis or viral meningitis, common, but there is another, you know, category of encephalitis, which is immune-based encephalitis, which has nothing to do with viruses per se, but somewhere maybe in their, like, you know, in sort of a, in their context, maybe viruses might have been involved at some point in time. So some of the further categories of immune-based encephalitis I will explain to you is autoimmune encephalitis, acute disseminated encephalomyelitis, subacute sclerosing panencephalitis, anti-NDMA receptor encephalitis, and PANDAS. PANDAS is pediatric autoimmune neuropsychiatric disorders secondary to streptococcal infections. That's a big name, but in simple word, when you look at the word PANDAS in context of pediatrics, just imagine a sore throat, streptococcal sore throat, leading to what? Encephalitis, autoimmune encephalitis, neuropsychiatric symptomatology. You know, so far, now you would say, yes, in pediatrics or maybe in our basic medical sciences, we have been taught streptococcal sore throat can be associated with post-streptococcal glomerulonephritis and in certain cases acute rheumatic fever as well. And these are the two complications that we normally is at the top of the head. But this terminology, PANDAS, has come into limelight in the last 5-6 years. This term was coined in 2016. So this is something which is quite new and coming into the limelight. And you would appreciate how much streptococcal infections are common in this country. So obviously, not of all of them are what you call streptococcal tonsillitis, but obviously, if it is tonsillitis, so relatively the proportion of all these things would be increased. Like if you see 10 cases and let's say one is streptococcal, so that is low. But if you see 10,000 cases, so you can just imagine like how many of them would be then strepto. So immune-based encephalitis, basically in all these encephalitis, the one thing is common: your immune system starts attacking the brain cells, or the in simple word, nervous system cells, and it depends where it hits. Especially if it starts hitting the cells in prefrontal cortex, you get all that complex neuropathy. If it starts hitting your basal ganglia, you will have all these like weird symptoms. If it starts hitting your temporal lobes and frontal lobes, you will get all those types of weird psychiatric symptomatology, hallucinations, delusions, uh, emotional ability, anger, temper tantrums, which we normally think are part and parcel of psychiatric illnesses. But why somebody who is fine absolutely up to 8-9 years of age, and all of a sudden one fine morning starts developing psychiatric symptoms, and over a period of time waxing and waning symptoms, uh, under child health, child and what this scams, whatever it stands for, they are seen by them, and still with all that drug or no drug treatment, no improvement. Could it be something like this? Could it be like anti-NDMA encephalitis? Could it be pandas? Who knows? Certain syndromes and developmental disorders can also lead to complex Angelman syndrome. You know, it's like it's a disorder of chromosome 15. So chromosome 15 short arm deletion, or there is another methylation process as well, defect as well, which can cause Angelman syndrome. And the other counterpart of that is, depending on whether it's uniparental maternal disomy or paternal disomy, you can have Angelman syndrome and Prader-Willi syndrome. So they're very much like associated with one another, and both are associated with the deletions and problems with chromosome 15. So Angelman syndrome, that can cause neuropsychiatric symptomatology. Rett syndrome, is like it only occurs in girls because it's X-linked dominant condition. So after 6 months of age, all of a sudden, child who is developing well and will start regressing back on their developmental milestone. So this is something which is picked up in early life, so can be picked up easily. Fragile X syndrome, like this is basically happens in boys. Fragile X syndrome, kids can have ADHD. They've got large set ears, macroorchidism, and low intelligence, and they can have neuropsychiatric symptoms. But obviously, because of a little bit of what you call this, dysmorphism, probably it's relatively easy to pick up. Simply autistic spectrum children, or autism, is a very complex pathology. Recent sort of the the evidence that is emerging is, they say that it's basically a problem in the way the neurons they fire in the prefrontal cortex and in the temporal cortex. So they say it's basically a problem in the electric vehicle system, like in an intrinsic problem. Not that there is an organic pathology, it's simply the way the things they get the way the signals get transmitted in brain. So that causes this spectrum of autism, like from low end to high end. And these kids can also have like complex neuropsychiatric problems. Substance abuse, toxidromes, prolonged steroid use, somebody who is taking oral steroids for a prolonged period of time, especially those who are, let's say, on some form of juvenile idiopathic arthritis, or let's say as brittle asthma, things like that, they can sometimes develop complex neuropsychiatric etiology. Or those who have been, what's it called, the organophosphorus pesticides, that sort of poisoning. They used to be called as mad as a hatter. I think this was the term used for this organo. They've got a lot of lacrimation and salivation and fever and what you call this sort of all over the place, anger and hallucinations and things like that. So phosphorus poisoning can lead to complex neuropsychiatric. But these are like, something which would be of acute etiology. Hormonal changes like certain thyroid disorders, certain forms of thyroid, both increased thyroid hormone and decreased thyroid hormone, both can cause problems. So thyroid storm like thyrotoxicosis can cause neuropsychiatric symptomatology. Low can also cause. And then vitamin B12 deficiency. Nutritionally, vitamin B12 deficiency, and vitamin B12 deficiency is quite treacherous. It is coming more and more into limelight because, I mean, normally when you think of vitamin B12 deficiency, you think like, oh, vegetarians, probably those people who are on strict vegan diets. But it's not the case. Recently, remember those people who are normally vegans, they are quite aware about their diet. So they usually take these supplements. So it's very rare for vegans to have vitamin B12 deficiency. Most of the vitamin B12 deficiency occurs in those people who are non-vegans, and it occurs for so many reasons, okay? And the further crux of this lecture on this thing, vitamin B12 deficiency, because I was going through some research updates in the update.com, and in the last 3 years, from 2020 to 2022, it's been showing that an increased number of children are having vitamin B12 deficiency despite what? Despite, excuse me, despite having normal B12 levels. You say, what's this? Vitamin B12 levels are normal and you've got vitamin B12 deficiency? Yes. Yeah. And one of the most common reason for some of the vague neuropsychiatric symptomatology in children as evidence is coming up. So before going into that, how should we work up? I mean, this is an algorithm. Like, let's say, where should we start from? If somebody presents with neuropsychiatric symptomatology, new or old one, if given a choice, okay, what investigation would you do? So starting with the very simple one, a full blood count with smear and anti-streptolysin O titers. Why would we do FBC with smear and ASO? Yeah, exactly. I mean, you are basically looking at megaloblastic anemia. We call it megaloblast, like, the large RBCs basically are associated with the pernicious anemia. And I will come to that in a moment. So basically with full blood count, you are not looking at only at the general, but with the smear, you are looking at the red cell morphology as well to see if the red blood cells are quite large, okay, and that can point towards, like, these can simple point, though these are not diagnostic tests. They just like give you an idea that if something could be wrong with, like, one of the etiologies that we talked about. Thyroid profile is something that we can do, like TSH and T3 and T4 levels. So again, if there is a problem with thyroid hormones or thyroid gland, that can pick it up. Why would we do urinary toxicological screening? Obviously, adolescents coming up with all of a sudden, being all over the place, anger tantrums, dilated pupils. So you would like to see if they have taken cocaine or they have taken contraband drugs. Most of the contraband drugs like LSD or something, they're going to, like, interfere with the thought process, and they would not be well oriented in time, place, and person. So a urinary toxicological screening is something that we can do. Like, now after this, like, probably these three can be done within the context of an ED, like, ED setup. But if needed, lumbar puncture can yield important, sort of a diagnostic clues, because if you are suspecting somebody to having NDMA, and stands for N-D-methyl aspartate receptor something, so these NDMA receptors are there on the neurons. So these antibodies are formed against these receptors, and when they destroy these receptors, what happens? The neurons are also destroyed in the process. So this anti-NDMA receptor antibodies, so if these antibodies, because these are the antibodies that they attack those receptors, if they are present, the lumbar puncture, the CSF fluid can be analyzed to pick that up. And you can also check for CSF proteins, because CSF proteins would be elevated in case of immune mediated encephalitis. For example, if you are suspecting, like all those conditions in which there's some immune mediated destruction, whether it's multiple sclerosis, whether it's like ADEM, whether it's the SSPE or something, CSF proteins would be elevated. Like generalized proteins are elevated, but then the further subclassification, further, they are very expensive tests where you have to check for specific types of what you call, you do this what they call this, where you get this waves of which type of antibodies, known as spectrography, I think so. Spectrography. Pardon? Yeah, electrophoresis or spectrography, whatever. I don't know what was the exact number. I was just coining it, maybe thinking you might be right. So, lumbar puncture, not for only for meningitis, like the typical, sort of a view of lumbar puncture is that we want to differentiate between bacterial viral meningitis. It's not only meningitis. In case of encephalitis, it can give us important clues. Not only for these things, you can also check for certain antigens, not only for proteins, but certain antigens. For example, like in acute viral encephalitis, you can check for that for herpes simplex, viral PCR, etc. ELISA test and different types of tests can be done. Then MRI. MRI is important because MRI can give you a very good picture of the sort of the gray cells and white cells anatomy, because certain types of illnesses would affect a particular types of areas or particular types of matter in the brain. Like it can affect certain disease, they affect predominantly the white matter. Certain disease they affect gray matter. Certain disease they would affect gray as well as white matter. So it can give you the extent of involvement of the nervous system, especially the brain. If you're thinking of neuropsychiatric symptoms and you're thinking that it could be something, MRI is an important part of this whole workup. And if MRI is showing you something, then it can be further supplemented by what we call as functional scanning. So positron emission scanning, or SPECT, which stands for, I think, some form of proton emission, CT, something like that. That can be done because those functional scanning, what it does, it looks at the metabolism. It not only does the scan, it looks at the metabolism of certain metabolites in various parts of the brain. So if a particular area of the brain is affected, the metabolism in the cells would be affected, and it gives you different forms of colors, because they give different types of isotopes, and those isotopes, as they are metabolized, they would emit different types of colors which are picked up on the gamma camera. So functional scanning is a very important and very good supplemental modality, diagnostic modality, in addition to MRI. And then last but not the least is the metabolic panel. So metabolic panel, basically, I mean, if you start doing test for, let's say, phenylalanine, and then if it is not, okay, let me now check for MSUD, let me check for something, isovaleric acid, things like that. Metabolic panel basically is a kit which can test for all those things. I think Gupta might know it better, because in the USA, you can order a metabolic panel. I think it costs $1,200 or $1,300 a kit, which tests for like at least 15-20 metabolic conditions. Okay, so moving on. Now, I am especially focusing now on vitamin B12 deficiency. Why? Because vitamin B12 deficiency, in the last 2-3 years, data is coming, like the evidence is showing up that this is becoming more and more common. Now this diagram looks a bit complex, but let me simplify. Most of the vitamin B12s come from animal sources. So what happens is that when we take any source which is good source of vitamin B12, as it goes inside, it's not like a simple like iron where it would go into the jejunum and get absorbed from there. The absorption starts right in the stomach, in a way that in the gastric fundus there are different types of cells, the gastric parietal cells, which not only secrete gastrin, they also secrete a protein known as intrinsic factor. So this intrinsic factor combines with vitamin B12, vitamin B12 cannot go down and cannot get absorbed unless and until it combines with intrinsic factor. This is step number one. So if you have got no intrinsic factor, whatever vitamin, even if you are taking tons of vitamin B12, probably majority of it is not going to get absorbed. It will just like be flushed away from your body. Now this, once, let's say if your intrinsic factor is like, is working well, your cells are producing that, so it would combine with intrinsic factor and then it would travel down till it reaches the terminal part of the ileum, just close to the colon. And from there, this combination of intrinsic factor and vitamin B12 that gets attached to the receptor, and only it would attach to the receptor if intrinsic factor is associated. If the intrinsic factor is not there and vitamin B12 alone comes into this part, it would not get attached to the receptors. So only if this complex of intrinsic factor and vitamin B12 cobalamin, they are attached together, only then it would be absorbed by the intestinal epithelial cells. Once it is absorbed from the intestinal epithelial cell, then it goes into the liver, and from liver, it is metabolized and for different functions of the body, especially in formation of certain types of ingredients for the integrity of the myelin sheath, but usually some of it stored in the liver as well. So usually the liver has got enough stores for to, even if you're not taking any vitamin D, we have got enough stores to have it for 2 to 3 months, like 2 to 3 months storage tank is there in the liver. Now those people who have got, let's say, Helicobacter pylori infection, or those who have got achlorhydria for immune mediated destruction, or those who have got, let's say, who are on proton pump inhibitors for their gastric acidity, or those people who have got everything fine but they have got antibodies against intrinsic factor. So there are two types of antibodies. One could be antibodies against intrinsic factor, the other could be the antibodies against intrinsic factor receptors. And these conditions are, for some reason, these autoimmune condition in which you have got antibodies against intrinsic factor or intrinsic factor receptor, that is increasing. So you are not a vegan, you haven't got like any peptic ulcer disease, you haven't got any other, but you have got, let's say, the child has got problems with let's say antibodies. And there is another interesting, it's not only once it absorbs into the blood and it goes into the liver and then goes into the cell, you have got certain transporter proteins, transcobalamin, and these are different types of transporter proteins which carry. So these transporter proteins take them to the cells. So if you've got issues with the transporter proteins, again, vitamin B12 would be circulating in your body, it would not go into the cells. You measure their vitamin B12 levels, that would be normal, still they would be deficient in vitamin B12 because there is problem now with the transporter proteins inside the blood. So if everything else is fine, it comes into the blood, but finally it cannot be taken into the cells that need it. And I'm talking about the nervous cells, the cells of the nervous system that need it, and it cannot go inside it. So you can have a normal B12 level and still be deficient in B12. So you can have problems with your dietary intake generally. If you divide like people who are vegans, but again, that's not the issue these days. You can have problem with absorptions. So if for one reason, if you have got peptic ulcer disease, you have been taking proton pump inhibitors, you've got achlorhydria, you've got like Helicobacter pylori, or you have got problems with the ileum, distal part of the ileum. Let's say there has been an intestinal resection, or there has been, let's say, chronic infection in the ileum. Like there used to be a term called fish tapeworm infestation, Diphyllobothrium latum, it used to be called in parasitology. That's usually in the tropics. That gives heavy infestation in the ileum, can cause absorption problems with this thing, or short bowel syndrome, or bacterial overgrowth syndrome. People who have got surgery or some reason, they could have bacterial overgrowth, and that can all lead with, absorption. They can lead to absorption issues with vitamin B12. So as I said, like, this is a very complex sort of physiology of vitamin B12 digestion and absorption, and at various parts it can have, issues, either with diet, either with absorption, either with transportation. Back in old days, we used to had a very good test called Schilling test. So Schilling test used to be done, in which they used to sort of, give you cobalt, radioactive cobalt level vitamin B12. So they would give you radioactive vitamin B12, and then they would measure it's like, whether it's like, because if the radioactive goes inside your body, if you have got gamma cameras or something, you can like pick it up. And basically what they used to do is, like, if you give too much heavy dose of vitamin B12, which is labeled with the radioactive cobalt, that is cobalt 58, some of it would go into the urine. So if it is getting absorbed into your body, then only then it would appear in the urine. If it is not absorbed, so what would happen? You would not get that in your urine. So this way they would, try to find out where is the problem if somebody was having vitamin D deficiency, vitamin B12 deficiency. Nowadays what they do is, there are three tests: vitamin B12 levels, that is hydroxycobalamin levels, or more important than that is MMA and homocysteine levels, methyl malonic acid and homocysteine levels. I would go, where is that? I think probably missed that slide. Okay, let me explain that. I think probably that slide is not here. So vitamin B12 levels, that is actually measures the level of vitamin B12 present in your blood, so whatever is there. But as I told you that vitamin B12 levels can be normal, and you still might have, low vitamin B12. So if somebody is having neuropsychiatric symptomatology and their vitamin B12 levels are normal, you cannot simply exclude vitamin B12 deficiency based on that. So the more sensitive test is MMA and homocysteine, methyl malonic acid and homocysteine. Now normally vitamin B12 actually helps in conversion of methyl malonic acid into another substrate which is healthy for for the neurons. But if there is vitamin B12 deficiency, what would happen? Methyl malonic acid would not be converted into its metabolite, so the MMA levels would rise up in the blood. So they would rise up, and this high level of MMA is what causes neuropsychiatric symptom, because this high MMA is quite toxic to the neurons. It destroys the neuron, it destroys the myelin sheath. So this is basically, if somebody, let's say, why vitamin B12 deficiency would cause like problems with the neuron, it's simply because reduced vitamin B12 means reduced metabolism of methyl malonic acid. So methyl malonic acid would go up in the blood, and that is quite toxic to the neurons. The other level is homocysteine. Now homocysteine not only gets elevated in what you call vitamin B12 deficiency, because it is also, and its metabolism is, vitamin B12 acts as a cofactor. So if vitamin B12 is not there, homocysteine levels would go up in the blood, and homocysteine also is not a good thing. High levels of homocysteine actually causes problem with the neurons. But homocysteine can also be elevated in folic acid deficiency. Can also be increased in folic acid deficiency. So the thing is that if both are raised, let's say methyl malonic acid and homocysteine, then the problem is vitamin B12. If only homocysteine is raised and MMA is normal, then it is folic acid problem. Because B12 and folic acid both are required for homocysteine conversion to its metabolite. For MMA, only vitamin B12. So that's why they say you have to check both, because if there is, let's say, folic acid deficiency, and you give them vitamin B12 without giving them folic acid deficiency, without giving them folic acid. So what would happen? You would just, like, that MMA is normal, but homocysteine levels would continue to build up, and that would further, sort of cause havoc with the neurons. So that's why when you are checking for B12, it's also important that we check for folate levels. And the best test for that these days, more sensitive, more specific, is MMA and homocysteine levels, because vitamin B12 itself is just a screening test. I mean, and again, with that screening, it has got low sensitivity, because you can be having false negative in that. Normal, like, some people who have got like low levels, or at the lower level of the normal range, and they can still be vitamin B12 deficient. So the thing is that these days, no shilling test. These days, vitamin B12 and MMA and homocysteine level, only these three tests. They can, yes, if there are issues with these, then there are further supplementary tests as well. Like, you can check for intrinsic factor autoantibodies, because if you're suspecting that, especially if there is macrocytosis, if there is megaloblastic anemia, then you would check them to see where the problem is. Like, if there is a problem with antibodies, then you will have to check, see if the intrinsic factor antibodies are present or not. Normal recommended daily allowance of vitamin B12 is usually in micrograms. So if you look at the age, it's usually like around 0.5, okay, which increases to around 1 at, after 1 year of age. And in like adolescence or something, then it increases to around 2. So the average is around like 2 to 2.5. In pregnant and lactating women, it slightly goes a bit up, but like, starting from 0.5 to 2.5 is the dose, like, sort of standard recommended daily allowance, which should be present in your diet to have a steady state of vitamin B12. But again, this is only valid if you have got intrinsic factor present. No matter with this 2.5, you make it 24, you make 240. If you have got no intrinsic factor, if you got problem with the stomach, you've got problem with the ileum, that's not going to get absorbed. You will go into deficiency. So usually the normal stores are there for 2 to 3 months, and after that, people, they get deficient if they are having problems. Normal vitamin B12 levels in nanogram per liter, usually different labs, they use different reference range, but normal could be anywhere from 200 to 1000. 100 to 200 is considered to be borderline or mild deficiency, and less than 100 is considered to be severe deficiency. So this is nanograms. Some use picograms as well. So I mean, obviously in picograms, that would go, there would be different levels. So you just see whether it's ng or pg per liter, different lab. But anyhow, as I said, like, if somebody falls in borderline or mild deficiency, it's very, very important. Like, in a normal person, if vitamin B12 levels are normal, you do not need to do any MMA or homocysteine level. Somebody who's got like some symptoms, neurological or psychiatric symptoms, and they turn up to be 100 to 200, somewhere in between, and they definitely need to undergo MMA and homocysteine levels. And obviously, where it is severe deficiency, that becomes a must. Some of the neurological changes that occur in vitamin B12 deficiency, because again, we are talking about neurological and psychiatric symptoms. So, because the prefrontal cortex involved here, where most of the complex psychiatric symptoms, they evolve from. So they can have delusions where they've got like false beliefs in something. They can have illusions. Illusion is basic. Illusion, anybody can have illusion. Like, illusion is if I mistake something. Like, for example, there is a rope and I think it's a snake. It can occur. Like, delusion is where you have got a faith. You believe that it is still. If somebody tells you that this is not snake, this is a rope, see, it is a rope, and you say no, this is a snake, you have got a firm belief in a false thing which other people don't agree. That's a delusion. Hallucinations, it's more of a visual or auditory. So when you see some things which do not exist, and basically you think that as a reality, you can have visual hallucination, you can have auditory hallucinations when you hear people talking to you and things like that. Cognitive impairment. So cognitive impairment is a very broad term. It's simply lack of concentration, confusion. It can have different names like confusion, uh, not able to focus, brain fog, blah, blah, blah. Dementia, well, this is more common in older age where the dementia process can be aggravated. I mean, dementia is quite common in UK in old age because of various reasons, vascular dementia or Alzheimer dementia, blah, blah, blah. But like dementia can, any type of dementia can get accelerated if they've got a coexisting vitamin B12 deficiency. It doesn't apply that much in context of pediatrics. Optic atrophy, yes, visual loss because of the optic nerve atrophy is one of though if somebody is having optic atrophy, I mean, I think in adults probably they would look for multiple sclerosis. But remember, multiple sclerosis is just like a sister phenomenon of vitamin B12 deficiency. They present the same way, like complex neurological lesion here and there. Spinal cord, typical subacute combined degeneration of spinal cord doesn't happen that frequently, but they can have diminished sensation. People coming up all of a sudden, one fine morning, oh, I can't feel in my left hand or both hands and things like that. And everything is fine. I mean, some of us would even go to scan their brain scans and everything, thinking it might be stroke or something. But I mean, who, like another child, I mean, a child who has got no what you call risk factors, why would somebody get stroke and something? So could be because of vitamin B12 deficiency. So they can have diminished vibration sensation, proprioception, but not only that, they can also have like diminished light touch and numbness and all these things. So glove and stocking paresthesias, reflexes, just simply tingling and numbness in any part of the body, even if it's not making any dermatomal pattern, like weird symptomatology. I've got numbness here and I've got numbness here. So, or numbness here and here. So, what it is, it's not connecting, like, so this type of weird sensory phenomena can be attributed to vitamin B12 deficiency. And to the extent, these days, what I'm doing is like any child who I see who has got these types of symptomatology and they are otherwise fine, no other thing, I usually ask them to take vitamin B12 supplements. Again, not very much scientific in the sense that, if there is problem with the GIT, then probably that oral vitamin B12 is not gonna do its job. Probably they would need intramuscular. So intramuscular is better. But again, with intramuscular thing is that has to be done by GP, because these are alternative injections which have to be given every other day for 2 to 3 weeks. This is what the BNF recommends. I think it is 1 milligram every other day. Or if you have to give them oral, then it's 50 milligram B12, which has to be taken at least for 3 months, reassessed after that, and then either continued, or it's like a physician discretion if you want to continue for the rest of life. But this is a vitamin which is completely harmless. So even if somebody doesn't need it and you give it, there is no harm in that. There is no toxicity because of vitamin B12. Fine. So you can have these peripheral nerve involvement. Then you can have some cardiovascular disease as well, like, because of the increase in homocysteine levels. Homocysteine increase not only damages neuron, it can lead to what we call as a hyperclotting state, and that can sometimes predispose. Those children are not that much affected to that, so more common in adult, but there is a theoretical risk. Neural tube defects can happen if these girls, they become pregnant, especially teenagers or something, so they can have their own kids being born with the what you call, encephalocele or spina bifida or things like that, neural tube defects. Other manifestations are like, hematological manifestations, it causes megaloblastic anemia. It can interfere with the functioning of the white blood cells as well. So some people can get repeated infections, can sometimes cause jaundice. One important thing is that it causes hyper and hypopigmentation both. So if you see somebody who's got dark or fair knuckles, like as compared to the rest of their skin, think of vitamin B12 deficiency, especially if they've got weird symptomatology and they've got some like sort of hyper or hypo, both pigmentation, because this can interfere with melanin. So either more melanocytes or less melanocyte, both can can happen. Okay, so just to see the knuckles is easy thing. You can just visualize and see if that sign is there or not. This is the thing that I was talking about, that some of the kids have got this problem. They have got transcobalamin. This transcobalamin is the protein which is responsible. So transcobalamin 1, 2, 3, 4. There are 4, 5 types of transcobalamin. Transcobalamin 2 is the main transporter protein to carry vitamin B12 once it is absorbed from the ileum. But if there is problem with this thing, so either it is deficient or not working properly, there can be lot of neurological symptomatology, but most of these symptomatology occurs in early age, so usually like around 1 or 2 years of age. So these kids can have failure to thrive. They can have, like, vomiting of unknown origin. They do get neurological dysfunction. A few days back, month ago, I saw a child 2 years of age, though I didn't think at that point in time of this thing, but in a retrospect, reflecting on that, is I think probably there was vitamin B, because that child had a history of vomiting for some time, and put down to reflux, given anti-reflux medication, not improving, and then for a few days he was not walking, so he was very like jelly like the tendency to fall or something. So when I examined it, everything else was fine, nothing, I mean, as usual. But I mean, I tried to do reflexes, but reflexes, to elicit reflexes, deep tendon reflexes in a 2 years is almost next to impossible. Anyhow, tried to leave him on the floor and see if he tries. He was not like cooperating with that or something, but his legs were a bit slightly, I mean, to me it looked like the muscle was slightly hypotonic. But anyhow, there was nothing else on which I could go. So I thought maybe this is some form of what you call this Duchenne muscular dystrophy, the milder form, but as a Becker's muscular dystrophy. And he was a boy as well. I said, okay, well, fine. Did cannulated him, did the CPK levels and other things, and he had mom told that he had a heliotrope rash. I was thinking of dermatomyositis. Anyhow, CPK levels would. But everything came out normal. I came to know he was sent for further investigations to Abilene or something. But then I was like, it could be vitamin B12 deficiency going through these things. It could be some form of transcobalamin deficiency, like vitamin B12 going over and prolonged. And now he's having these sort of a weird neurological symptomatology. So these different types of genetic defects that can cause either defect synthesis or defect half-life of these proteins, and that can present with different types of symptoms, not only neurological but other generalized phenomena as well. Like they can present with visual problems, they can present with vomiting, they can present with the sort of recurrent infections, failure to thrive, blah blah blah. So these are another group of disorders which normally would not respond to any form of because the question is, even if you give them intramuscular vitamin B12, so how would that be transported into the neurons if the transporter protein is not functioning? So they say the only way is just to give very high doses of intramuscular, because some of it would simply seep away and make itself in the adjacent parts, like maybe a little bit of that transcobalamin which is working, that would be overloaded with the high dose of vitamin, and that might be able to cope with some of the what you call the deficiency or the deficient vitamin B12 in a way that would be replenished, but doesn't look that scientific. I don't know what's the actual science behind that, but that is one of the most resistance form, which I think today they say like it's treated with very high dose, but what is the outcome, long-term outcome, we don't know. Going on to, this is the diagnostic algorithm. I've already talked about that, like so depending on vitamin B12 level, whether it's normal, low normal, or low. So again, like levels, if they are on the lower side of the normal, then you have to do methyl malonic acid and homocysteine levels. If you have only like one test to do, then you will do methyl malonic acid levels. So methyl malonic acid levels are high. That simply means that the child has got vitamin B12 deficiency. Now that vitamin B12 deficiency, where it's coming from, is it pernicious anemia? For pernicious anemia rule out, you need to do anti-intrinsic factors antibody. Coming down to treatment, two types of treatment to make it very simple is oral and parenteral vitamin B12. So oral vitamin B12, if you have to give it, you have to give it in quite a high dose. Again, as I told you, normal requirements are between 0.5 to 2.5 micrograms. But here you have to give 50 milligram, okay, per day to make sure that it gets about. The thing is that only some of it would be utilized, rest of it would be just like flushed away from the body. Intramuscular is again the BNF and the British Society of Hematology. They say if somebody has got symptoms of like neurological symptoms, then they have to be given alternate day intramuscular vitamin B12 for 3 weeks, or till the resolution of neurological symptoms. And those who do not have the symptoms, they should be given for 14 days, like just like by chance their vitamin B12 levels comes out to be low, but they do not have any symptoms, they should be given IM B12 1 milligram. The dose is 1 milligram, 1 milligram of hydroxycobalamin every alternate day for 2 weeks. For the other, it's 3 weeks, or as long as the it takes for the symptoms to resolve. Oral can be given for 2 to 3 months and then review, and again the free physician discretion. So if you have to give like pure vitamin B12, that has to be given in a high dose. If not, then usually it also comes as a part of multivitamins. So maybe age specific multivitamin Velcades or Centrum Junior, things like that, they contain all these vitamins, not only B12 but maybe B1, B6, B12, riboflavin, pyridoxine, and all these things, and they can be given. The good thing is that you don't have to worry about the side effects of these things. They're almost non-existent, so it can be safely given even if that's not the case. So my friends, this was all about vitamin B12 deficiency in context of complex neuropsychiatric conditions. Going back to the initial cases, these were taken from the journal where these were published as three cases, clinical cases, and all of these three cases, their ages were 15, 16 and something like that, like adolescent. Two of them were already on fluoxetine and aripiprazole, something to treat there, and they were still not getting controlled. But once they were put on vitamin B12, parenteral vitamin B12, their symptoms, they resolved and they became absolutely fine. All the complex neurological as well as psychiatric symptoms, they resolved with vitamin B12. So with this, we come to the end of this lecture. If you've got any questions or you want to share your experiences or anything, please feel free.